Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. Today is Tuesday, January 31st, 2023, and I want to thank you, as always, for joining our Ask Dr. Arwady segment. This is your opportunity to get your questions about COVID and more broadly about public health in Chicago answered. I'm joined by a guest today. This is Matt Richards. He is the Deputy Commissioner for Behavioral Health at the Chicago Department of Public Health. You've been on a number of times before, I know, because his bureau, with his whole team, handles in what we call behavioral health, which means all of the mental health work, all of the substance use work, and all of the violence prevention work that the health department is involved in. So when we think about COVID and indirect effects of COVID, behind the scenes, so much of what we've been doing has been out of Matt's bureau. So welcome. Do you mind telling folks a little bit about the kind of work, your team, sort of what you've been doing, how things have changed during COVID, and then you'll be able to put questions in directly for either of us.
Yeah, thank you. It's good to be on the show. So I'm a licensed clinical social worker by training. My background's in the treatment of mental health and addiction and people that struggle with both mental health and addiction. So we, over the last 3 years, have been quite busy.
To put it mildly.
Getting close to funding a mental health clinic or operating a clinic in every single neighborhood in the city. We're going to talk today about some exciting news about integrating mental health and substance use professionals further into our 911 system. We fund overdose prevention all around the city. We have Narcan in every single library in the city. That my team was responsible for that, standing up a hotline that you can call to get connected same day to one of the 3 FDA-approved medications that treats opioid use disorder. My team works on street outreach and community violence interruption. So these are the groups of organizations around the city that proactively promote peace in communities and try to intervene in violent conflicts to produce retaliatory violence. So lots of things on our plate, and excited to talk about 911 response today.
All right, perfect. And just to remind you, as always, you can put your questions directly into the box below for either Matt or me. You can also use the hashtag AskDrArwady on either Facebook or Twitter. We will turn in just a second to our COVID dashboard. We'll go through a presentation of where are we on COVID, and also, Matt, I'll let you do a quick overview of some of the 911 expansion work related to embedding mental health and substance use professionals. And then in the second half, we'll turn back and take all of your questions, but you can put them in now. So as always, let's start with our COVID data. If you go to chi.gov/COVID-, just a reminder, we've been talking about this for the last few weeks, but when we passed the 3rd anniversary and got through the holidays and we're looking to be in a pretty good place from COVID, we have switched the updating of this primary portion of the dashboard to weekly. You can click here if you want to read more about the data behind that. As I've said in prior weeks, behind the scenes, CDPH continues to monitor every bit of this daily. We continue to watch closely. We can always switch reporting back. But to be in line with the state, with the nation, and frankly where we are right now in COVID, that makes sense. If you have more questions about that, put that in and we can come back and show you. But overall, you can see everything's looking green again. And this, of course, is in line. We'll talk a little more in a minute. But we are at a low COVID community level in Chicago. I'm thrilled about that. It's been mid-November since we were at a low level. We were at medium through most of the holidays, and we did not hit a high level. And I can't tell you how happy that makes me, because we hit a high level when we start to see a higher level of hospitalizations, more severe outcomes, a high percentage and number of people testing positive in laboratories, meaning largely in healthcare settings. And I want to thank everybody in Chicago who helped us keep this, to date so far through this winter, really in good control using all the tools we have. So this is what the dashboard is. Everything's green except our vaccination. We're still doing 1,300 to 1,400 COVID vaccines every single day in the city of Chicago. That is down a little. But other than that, all of the metrics are looking good. And just to remind you, below here is where you can click and see hospital capacity here is still updated in a public-facing way every single day. If you look, our most recent update here, like let's look at what's happening with non-ICU beds. You can see this was last updated yesterday on the 30th. We have 202 patients in non-ICU beds with COVID-19 across all of our hospitals, but we have 19% of our non-ICU beds available. That's very good availability for this year. Here's the graph, so you can see over time that has continued to come down. Similar data, ICU ventilators. This is the piece we remain in a lot of ways the most concerned about, and so this continues to be updated daily. We also, down here is where you can see we have upgraded and actually are putting more in on both wastewater surveillance, variants and genomic surveillance, because these are a lot of the ways that we will monitor this in an ongoing way. And then finally, I just wanted to show you on vaccine coverage. Also with these updates last week, we have added in what our updated bivalent booster numbers are looking like. And if you look at this by demographic, and you can explore this later at your leisure, you will see that in addition to just the at least one dose in completed primary series, on the right here, just loading, is our updated bivalent booster dose data for Chicago. I'll just let that load a second. You can see citywide we're at 20%. Which is above the national average, but frankly doesn't make me that happy. I'm just waiting for it to load. Give it one more second. Slowly but surely. Lots and lots and lots of data is underlying all of this and the team. There we go. So you can see we've been sharing this out on Facebook, but now it is dashboarded. You're able to download this data and use it yourself off the portal. And you can see if we look by age here, people in their 70s are the most likely to have had that updated bivalent booster, which has been available since Labor Day, is the best protection against Omicron. But still, only about 42%, even of people in their 70s, have had that vaccine. And only 36% of those over 80, that is really worrisome to me. You can see those disparities by race and ethnicity are persisting. Women more likely to get it than men. So this is a lot of what obviously we continue to work on, but this is now available in a dashboard format. So just wanted to highlight that this isn't about pulling back on data. It's about evolving to continue to really focus on the things that are most relevant now. We are also continuing to update vaccine effectiveness every week, et cetera. Okay, let me turn to slides here a second. So first of all, off COVID a second, I wanted to just share, we're heading into Black History Month, and as part of the Black History Month celebration, our HIV team, part of our systemic infectious disease team, new for CDPH, it's actually a documentary. We've worked with many partners and professionals to develop a documentary about where are we right now in HIV. Again, sort of like COVID, really different tools, antiretroviral medications, PrEP medications, different approaches to prevention, different approaches to engagement. And so there is a documentary coming out called HIV and the Journey Toward Zero. It is all about Chicago. So it's professionally made. It's, what does getting to zero mean for those who have been living with HIV? In particular, what does it mean for Chicagoans who have been affected the most by HIV over the past 3 decades, especially Black, Latinx, and transgender Chicagoans? There will be a number of opportunities to see this around town, but also on February 8th, we will be launching it on CDPH's YouTube channel. So you can watch the documentary yourself at home. It presents a diverse group of Chicagoans, different ages, and there's a trailer and film information, resources, updates at journeytowardzero.com, and there's an Instagram at HIV0. So watch for that coming up. We're excited about it. It's a brand new thing for us to be doing, and I hope many of you take some time and watch that. Okay, in the news, Chicago and Cook County at a low COVID community level for the first time since mid-November. I already mentioned that, and I'll show you the data in a minute. But this means that the risk overall for COVID is back down to a low level. That means that most things have not changed, and we'll review that as well. But things like masks, certainly there are people who will continue to choose masks, who have reasons. They're immunocompromised, they're older, they're concerned, they're on a crowded L train, somebody's coughing. But it does mean that sort of at the societal level, while the risk is lower, those masks are less indicated. And that's good news. COVID is not over in any way, shape, or form. But being back at that low COVID level is based on our local data, and it reflects the risk right now. The other thing in the news that we've been getting some questions about is that just yesterday, the President Biden noted that they are intending to end the COVID national and public health emergencies tentatively on May 11th. And I know some of you, we were already getting questions about it. So this is a pretty big deal. I certainly think, based on the way the country is going from a data perspective, that this does make sense. I think it is important that we have some runway toward that. So I know there were conversations about ending this right away, which would be pretty disruptive for a number of things. So I can work with a May 11 deadline there as we are trying to do what we can to fill in. I'm happy to take additional questions there, but just off the top of our head, that means that most likely vaccines would no longer be free for people who are uninsured or underinsured. It means treatments would no longer be free for people who are uninsured or underinsured. It means that tests may no longer be free. But beyond COVID, there are a number of things tied to the emergency around needs for Medicaid re-enrollment, needs for an ability to do more with telehealth. There are things right here in Chicago that would probably change. So my team is working on a full analysis of this. We are in support of this at a high level, but I will say there are some things that I do not think we have gotten done as a country, like a Vaccines for Adults program. We have a program called Vaccines for Children that if you are a child in this country, even if you are uninsured, underinsured, we can get you your vaccines. We still don't have a Vaccines for Adults program, and that remains a concern, sort of a gap for me that I hope we address at the national level. So we can talk some more about that if you have questions, but these are probably the two big things in the news. Here is the data underlying our current low COVID community level. So I'll just remind you, this is done at the CDC level every week, and it's based on our number of cases. We want to be under 200 cases per 100,000 in the last 7 days. You can see both City of Chicago and Cook County well under 100 there. Those are lab-confirmed cases, largely people being diagnosed in healthcare settings, but also in Chicago public schools or people coming in to their doctors. All of those continue to be reported, and we're in a good place. The main one that had been keeping us at a medium level was COVID admissions, new hospital admissions per population in the prior week. And just this last week, we dropped under 10 per goal. And you can see the City of Chicago is at 8 and Cook County is at 9.1. So that continues to be, this is very much not gone, but under 10, that again, in a way that isn't as dependent on testing, pulls in, these more serious outcomes. That's a good space. And then finally, what percent of our staffed inpatient beds are occupied with COVID patients? The goal is to keep that under 10%. You can see we're well under that. So that is why we are at a low level. And in fact, the whole country really is continuing to do better from a COVID perspective. This map makes me really happy. The orange again, just 3.6% of U.S. counties are at that high level in orange. That's down from 6% the week before. And then 27% are at medium, and that's down. And you can see in Illinois, we no longer have any counties at a high level. We do continue to have some in a medium, but we are, Chicago, Cook, all of our surrounding counties are at a low level. We're just under that low level, so I want to know, there is some possibility over these next few weeks. Could we tip back to medium? We could, but we are a long way from high, and that is the thing that makes me the happiest, because high is where you really start to get more worried and needing to be thinking about, doing even more to make sure we're protecting everybody. So this is good news. Also, I noted this briefly, but just a reminder from mid-January, because we've been getting questions. As of January 25th, we are now updating that main dashboard every single week, but there are pieces of it that are still every day. We're monitoring every day. If at any point we have the emergence of a new variant of concern or there is anything of worry, we can flip back to daily. But I've got a lot of epidemiologists who work hours every day having that level of frequency, and I frankly want those epidemiologists devoting more of their time to some of the other things that are more important, frankly, where we're monitoring it. And so we've increased our public reporting and data availability for newer forms. That booster vaccine data I just showed you, more on local variants, local wastewater, all of which is on the dashboard. Why can we do that? Again, just to review this, we are through the holiday season. We are more than 1 year since our last major COVID surge, which was when Omicron emerged, and updated. We are now at a low COVID community level. We have these updated vaccine boosters are widely available. They are designed to protect against Omicron, which is still everything that we are seeing. And so where you are up to date against Omicron, you've done the most important thing for yourself, your family, and at the population level to help us protect against new variants. Testing is widely available. Treatments are available, and we can effectively treat it. And we have these other ways of monitoring COVID. And then finally, and I shared data on this, the death rate, thankfully, is so much lower than it was in the early days of the pandemic. Our earliest, we were having 50, 60 Chicagoans die every day. We had of people being diagnosed formally, we had an 8 to 9% mortality rate of every 100 people diagnosed with COVID, 9 of them were dying right at the beginning. That is now about 0.3%. It's much less than 1 in 300, and those are even people being formally diagnosed, not even including people who who are never seen in the health system. So this is where we are. It is good news. We are not done. We are still monitoring. Here's where we are on variants. The biggest one we're continuing to watch is that subvariant XBB.1.5. Just as projected, we are now at about 36.5% in the most recent week is that variant. That's been more or less doubling every week. Our doubling time is currently 6 days. I expect that to continue to increase. It's a little bit why we're on that low-medium threshold, but I'm not majorly concerned about it in terms of how it's showing up in the rest of the country. Just get up to date with your vaccines if you're not. That purple again, that's that subvariant. You can see it's almost everything now out on the East Coast, and it's still about 40% where we are. But we're watching it, and I'm not majorly concerned about it. It is the most contagious variant yet, though. Our SARS, again, you can go on the dashboard for more here, but our variant risk assessment is at medium, largely because of the way that XBB.1.5 is acting right now, and our wastewater risk score is at medium for the second week in a row, down from high. In terms of that booster coverage, you can look on the dashboard now, but I just wanted to put it in some context for you. We've done almost 550,000 doses. We'll pass 550,000 today, probably. And you can see we are beating the national average, but this is nothing to brag about. This is my biggest worry still, and especially that population over 65. You can see we're not beating the U.S. average there, and that is still who is the most likely by far to get seriously ill or die from COVID. Quick reminders. Do you think you're up to date with your COVID vaccine? If you haven't been vaccinated since Labor Day, it's time. This is true for everybody aged 6 months and up. Should be getting that booster. It is not too late, even though it is January. You should be getting it if you haven't. We continue to operate our at-home program. We're really committed to this. Even in this conversation of public health emergency ending and what does it look like as that changes, we remain very focused on making sure that people who need it are able to get this vaccine. But doing this now, especially if you know somebody who's uninsured or underinsured, we would love people to get totally up to date right now while it's still covered by the Fed. So give us a call. We'll do up to 10 people. Nothing's changed there. Flu and COVID vaccines available free of charge anywhere in Chicago for anybody over the age of 6 months. And also, while it is still free and widely available, Vax and Pax. It's not just about vaccine, it's about getting treatment. Paxlovid being the best known oral medication. If you're at high risk for severe illness, vaccines are the best protection, but if you test positive, regardless of whether you're up to date with your vaccine, there are treatments available. Paxlovid, widely available, free for the moment. and needs to be taken early, shortly after you're diagnosed. So reach out to your doctor or go to our website. There are pharmacies where you can get this. There are free at-home COVID tests. Again, this is the sort of thing that will also go away. So if you've not ordered yours yet, covidtest.gov, put them in. They get sent to you, no questions asked. Nothing changes. Whether that's the emergency declaration, whether that's the us being at a low level, nothing changes if you test positive for COVID-19. Days 1 through 5, everyone, regardless of vaccination status, should be staying home. People at high risk for severe illness should be talking to their doctor about treatment, like we just mentioned. Then day 6 or later, you can be out as long as you're doing better, but you need to wear a mask days 6 through 10. None of that has changed. Finally, we continue to, in partnership with city colleges, every Saturday for at least another few weeks, we are offering the free, widely available, both flu and COVID vaccines. You can get your first vaccine, your second vaccine, any of your boosters, anybody age 6 months and up. Come on out. We're at Kennedy King this weekend. This also will probably extend through mid-February, and then we will probably be ending this. So now is the time to be doing this. You can sign up in advance, but we'll also take walk-ins. As always, if you need a vaccine or have a booster, you have questions, come to the website or give us a call. We are still operating this 7 days a week, and we will help with whatever you need on COVID. Please know that that commitment is not changing. And with that, I'm going to hand it to Matt Richards. If you joined us a little bit late, Matt is our Deputy Commissioner for Behavioral Health at the Health Department. He's going to go over some slides about the expansion of our CARE program, and then we will turn to take your questions directly.
Thank you. So CARE, for those of you that don't know, is called Crisis Assistance, Response, and Engagement. It's our 911 program that integrates mental health and substance use professionals into the city's 911 system. This is something that we did starting in the fall of 2021. We have 3 mental health teams working around the city taking 911 calls. In the Lakeview North Center Uptown area on the north side, Auburn, Gresham, and Chatham on the south side, and then a group of neighborhoods, West Englewood, West Elsdon, Greater Lawn, Gage Park on the southwest side. Really excited to announce that we launched a new team yesterday. It's our first team that's actually focused on substance use and overdose prevention. So it's called our Opioid Response Team. That's who you see here on the slide, is members of this team. They started yesterday in the Humboldt Park and East and West Garfield Park neighborhoods, which are 3 of our community areas where we have the highest rates of drug overdose. And so this team consists of a paramedic and a peer recovery specialist. A peer recovery specialist is somebody who has lived experience of substance use disorder themselves, who's now in recovery and engages and supports other people who are living with a substance use disorder. And so we were really fortunate on this team to have our paramedics from the Chicago Fire Department partner with the University of Illinois at Chicago Community Outreach Intervention Project, which is where all our peer recovery specialists are from. And so this team, this first team focusing on substance use, will do follow-up with every single person in these 3 communities that we've transported to an ED, an emergency department, in the prior 72 hours for a drug overdose.
Because they called 911.
Because they called 911. That's right, because somebody called 911. So we're trying to get the person engaged in services, get them Narcan, get them started on a medication that treats opioid use disorder, that reduces the risk of having a future overdose, get them linked with other types of case management services or individual or group services that treat substance use disorder. So this is really, I think, significant because it's our first 911 team focusing on substance use. It's also significant because it's our first team that actually incorporates peers into the 911 response model. So, you know, we also announced yesterday, which we were really excited about, a much broader set of expansions. And so I want to share that with you. So the first one is what I just shared, which is our opioid response team started yesterday in Humboldt Park, East and West Garfield Park. The other thing that we announced is that we got approval from the Illinois Department of Public Health. They regulate 911 response in the state of Illinois. And so anytime we're introducing a new way of responding to 911 calls, we have to create a protocol that describes our proposal, who the team members are, the types of calls we're going to go to, how we make sure the calls are safe. And then the Illinois Department of Public Health reviews that, and we usually go back and forth with them to get an approval. So they approved a proposal from us that's going to allow our 911 response teams to start responding to a much broader array of mental health calls. So we're going to start responding to calls for check well-being. This is when somebody calls 911 and says, you know, I have a friend who's living with bipolar disorder. They stopped taking their medication. They're sending me texts that are very concerning. Can you go check on them? So we're going to start being able to respond to those types of calls, check well-being with a mental health component. Really exciting. We're going to start responding to more conventional law enforcement calls, trespassing and suspicious person, that have a mental health component. So this might be, I'm just giving examples. There's a person that's sleeping in the alleyway behind my house. They appear to perhaps have a mental health condition. Can you come and check on them and find out what's going on? That would normally be considered trespassing in 911. Usually it just gets a police response. So we have approval to start sending our mental health teams to those. We're also going to start going to suicide threat. So when somebody threatens to attempt suicide, up to this point, our mental health teams had been going along with a patrol vehicle, a police vehicle. We are now going by ourselves to those calls, and that's all starting in March.
And that's because there was a year of data.
A year of data.
That we were able to do this safely
right.
around other types of calls.
Yes. A lot of folks have said, you know, do you feel like this is going too slowly, the program? And the answer is no. It's going exactly kind of the way we hoped it would, which is that we had to collect enough data to prove to our regulator at the state that this is safe, to our partners in organized labor who represent all of our employees that are safe, to our policymakers that it's safe, and I think we've shown it is safe. We've had no significant injuries to responders or patients. We've had no arrests. So we've shown it is safe, and that's why we feel comfortable seeking this approval for new calls. The third expansion that we announced is that we're launching 3 more mental health teams. So we will have new mental health teams starting in the Loop and near South Side. Really excited about that. We will have another mental health team starting on the far north side, so Rogers Park, West Ridge, part of Edgewater. And then we're going to have another mental health team starting on the southeast side, so South Chicago, Hegwish, and a cluster of neighborhoods on the southeast side. We intend to have those teams all in place by this summer. So that's going to double the number of mental health teams that we have. We will after this expansion, I'll show you a map in a second, we'll have 6 mental health teams working around the city, and then that opioid response team. The last thing is we need to have new options for places we can take patients. If a patient calls 911 with a mental health or substance use emergency, we normally have 2 options. They either go to the emergency department, or if a crime was committed, they go to a police station. And we know there are some times that patients, for instance, do need to go to an emergency department, but a lot of the time, what the patient actually needs is to be taken to a setting where they can get wraparound services that are really focused on mental health and substance use. And so we're going to be standing up 2 new programs this year, which I'm super excited about. And Dr. Arwady, you know how hard my team's worked on this. One is a sobering center. So a sobering center is a place where people can be taken who are acutely alcohol intoxicated. And this gives us the opportunity to get the person fluids, help them sober up, and then really engage them around their substance use. What does their substance use look like? How is it impacting their life? How is it connected with other challenges? And we can really try to get them connected into services, get other services they need like housing, mental health, health insurance enrollment. So this is a program we're going to be standing up this year. Our paramedics can use this resource, our police officers can use this resource, our care teams will be able to use this resource to transport patients instead of an emergency department. The second thing is we are in the process of acquiring a hotel. You may have heard this, that some cities around the country, and I think it's a very good idea, are purchasing hotels. And it's based on something that Dr. Arwady, we worked on together related to Hotel 166, right, which was something, why don't you explain what Hotel 166 was, because you worked really hard on it, and it was an inspiration for us.
Yeah, sure, and we can talk a little more about this if folks have questions. But if you remember, during COVID, we stood up, it was called Hotel 166, and it was really work to proactively identify people who were living in homeless shelters in Chicago who were at high risk for bad COVID outcomes, who had a lot of health needs that were not being met, the unmet mental health needs, substance use needs, physical needs. And instead of waiting for people to get COVID and, you know, with all that goes around that, we needed to decompress shelters anyway. And so we moved some of these folks who were older or had high health needs into a stabilization hotel setting. We then worked with Lawndale Christian, other partners, to bring health care at the same time as housing, get these folks stabilized, and then move them eventually into permanent supportive housing.
That's right.
A really different model, but one that in the evaluation was hugely successful in terms of breaking some of the cycle. It is a relatively resource-intensive project, but we also know that it is meeting the needs of some of the folks in Chicago who, frankly, are unlikely to get their needs met any other way. And so we've been really wanting to figure out what does the sort of post-COVID Hotel 166 look like. And this stabilization, health-focused stabilization housing in a hotel setting that the city can own, that we're working with healthcare providers to get people's health first and foremost stabilized as we then are working on stabilizing their housing situation, I think is a really best practice. We're really proud of the outcomes that we had with so many people on Hotel 166. Health outcomes, housing outcomes, COVID outcomes. We know how to do this. It's just turning it into sort of a different setting, not around COVID. And it's one of the best examples for me. This is a very unusual thing for a health department to be doing, but we think it was a best practice, and it's something we're working hard to get done in the later part of this year.
Really excited about that, and I have a slide on it which I can show you a little more details about it, but I think that was a perfect summary. So this shows you the map of our expansion of our Care 911 teams. So that sort of darker blue color is where we have mental health teams working right now. That sort of royal middle blue color on the west side is where we have our opioid response team, which started yesterday. And then those yellow community areas are our new teams that we'll have in place by this summer. And the way we selected all of these community areas, just so you know, is we looked at the community areas that have the highest volume of 911 mental health calls over the last 3 years. And we simply sorted them. So at this point, Dr. Arwady, we and you, the public, I want you to know that we are in the 7 community areas, clusters of community areas, with the highest volume of 911 calls that have a mental health component. So we really strictly followed the data, and it's also nice that it reflects the geographic, the racial, ethnic diversity of our city, so more of our residents can kind of touch and feel the differences that these teams can make. So I'm really proud of our team and our partners who've helped us do this. This shows you some information about that West Side Opioid Response Team that started. I already sort of told you about that. This is the community areas that they're working in, following up with anybody that our paramedics have transported to an emergency department for a drug overdose in the prior 24 to 72 hours. The reason we do that, and Dr. Arwady, I know you know this, is that the greatest predictor of a future fatal overdose is having had a prior overdose, experienced a prior overdose. So this is the greatest risk group, and we're really excited to start engaging folks that have experienced a prior overdose to try to get them linked into services. This team's going to be really busy. This shows you the data, so this is really, you know, we post all these slides. So for folks that want to understand, well, how did you choose the community areas that you're piloting these new 911 teams? And I explained to you, it's strictly based on the data. This shows you the data. So you'll see the darker shading represents highest volume of 911 calls with a mental health component. You'll see on the bottom of this slide, we give examples of all the types of calls that we're allowed to go to. Mental health disturbance, suicide threat, suspicious person, check well-being, criminal trespass. And if you have questions about what any of these calls mean or want me to give examples, please include it in the chat. We already talked about the eligibility expansions, and I just mentioned that. Something I didn't mention is that we're actually able to serve children down to 12 years old. Up to this point, we had been serving children down to 18. Many of you have probably heard, you know, during COVID, we did see an increase, and this had been trending upward anyways, of crises, mental health crises among children. And I think the reasons for that are multiple, but it's absolutely something where we're seeing where more children are reporting suicidality, reporting depression, anxiety. So I think it's really important that these new teams, when we have a child who's experiencing a mental health emergency and it leads to a 911 call, that they can be met by mental health professionals. And so really excited that we've gotten that approval from the state to do that. I mentioned all the new types of calls we're going to go on. And then these are the new types of destinations. We already talked about the sobering center. I wanted to add one thing about, stabilization housing is that in the United States, one of the biggest problems that we have with folks who are living with untreated serious mental illness and addiction who are also experiencing homelessness is that we frequently either provide people with just housing, often shelter, so a shelter where you're with a bunch of other people, or we offer people healthcare services like addiction treatment or treatment for your schizophrenia. What we don't do a good job of doing is pairing housing where you have your own unit, you're not in a big shelter with other people, with really highly specialized services that treat your mental health, an addiction or substance use disorder that you may have, and your physical health. And what we learned, as Dr. already said during COVID, is that when you pair housing, where every person in Hotel 166 got their own unit in that hotel, with health care delivered by a team of people who came to know you as a person over time, it was a super powerful combination. We actually published a journal article in the Journal of the American Medical Association, one of the most prestigious medical journals in the United States, showing that when you do this, you improve people's blood pressure, you improve people's blood sugar. We proved that you can get people started on mental health and addiction treatment that otherwise wouldn't access it. So this is a huge lesson learned. And we're now going to take that same approach and focus on folks who have untreated serious mental illness, addiction, or both, who are also homeless in the city of Chicago, and excited to get that started. So that's what I have for you today. I think lots of exciting things happening, and please type your questions in the chat.
All right, thank you. So while we transition into calls, already there's some folks, interested in some of that 911 data.
Great.
So can you just, while I pull up some of the questions here, what percentage of 911 calls do have a mental health component? Like, how does that fit into future planning? Shouldn't this be citywide? There's a number of conversations about that.
So let me explain that. So it's a really important and good question. So about 3 to 5% of 911 calls are strictly related to mental health.
3 to 5%?
Yes. Mm-hmm. Now let me explain sort of how we know that a call has a mental health component. That might sound kind of obvious, but it's actually kind of complicated, and it's something I've learned as we've worked on this over the last 2 years. So one way we know a call has a mental health component is the person who calls says, I'm having a mental health emergency. My son is having a mental health emergency. My neighbor's having a mental health emergency. That's really obvious, right? Because they're telling us. And so we code that as a mental health emergency. A second thing that happens all the time is that somebody sees somebody they don't know on the street having what appears to be a mental health emergency. So Dr. Arwity's walking down the sidewalk, and she sees Matt on the street corner appearing to really be struggling. Perhaps I'm responding to stimuli that other people can't see. Perhaps I'm shouting out loud, I want to die. I can't stand my life. Right? And Dr. Arwity calls 911 and says, I see this person I don't know, he appears to be having a mental health emergency. That's the second type of thing. The third type of thing that happens is the call comes in as something completely different. Somebody calls and says, there's this person that's sleeping in the lobby in my building. There's a person that is walking around in my backyard, or there's this person that keeps walking back and forth on the sidewalk in front of my house. They're not breaking any laws. It looks like they're not doing okay, right? And so that actually gets coded as something different. It might get coded as trespassing. It might get coded as suspicious person. And then when we get there, our team that gets there could be police officers. It's usually going to be a team of patrol police officers. We'll get there and then they'll say, oh, wow, okay, so there's a mental health component to this, right? We might not have noticed it in the 911 center, but the team that got there did. And so when you lump all of that together, Dr. Arwity, it gets you into that 3 to 5% range. Now, please keep in mind, that does not include substance use. That does not include homelessness. That does not include people that have conflicts in their family. So there's lots of other types of calls in 911 that probably could be well addressed by other groups of professionals, but the strict mental health answer is 3 to 5%.
All right, perfect. So there's a lot of different kinds of questions coming in.
Great.
I think we're going to go back and forth a little bit between some COVID stuff
Good.
and some questions for you. So let's do a little bit on COVID. So first of all, some questions about bivalent booster. I see Ina F. Miller on Facebook saying, how often should we get the next booster, or is that undetermined at this point? What's after the bivalent shot? Andrew is asking, when will the vaccination run out and not work anymore? I'm going on 4 months out. I get worried I'm not protected anymore. Okay. So lots of conversation happening right now in that space. Here is where when I look at all of the data and all of the national conversations that are happening, whether that's the FDA and its advisory group, whether that's the CDC, whether that's our own experts here in Chicago, all signs are pointing to us treating COVID vaccines similarly to how we treat flu vaccines. We see COVID continuing to mutate. That is just happening. Every single time COVID spreads, that is an opportunity for a new variant or a subvariant to emerge. And just like flu, there are lots of different strains, and we see different ones take priority in different years. Every year, we make a new flu vaccine to be the best possible match to the flu that is circulating in the southern hemisphere's summer, which is our winter, because it takes a few months to make a new vaccine. All signs are pointing to that being what we do for COVID. So my guess, don't know this 100%, but my guess, based on everything that we know now, is that there will likely be an annual COVID booster, just like there is an annual flu vaccine. If you have had the most recent bivalent booster, meaning you've had a vaccine at any point since Labor Day, you are up to date. I do not anticipate that you need to get another booster in a few months or another booster a few months after that, like we were doing as we were still learning kind of how much are we changing and how long does that immunity last. I always want to put a caveat on there that if we were to see a new variant of concern or a variant of high consequence emerge where the vaccines are really not being effective or there's some other major trouble, COVID is not done evolving. It's been a year, though, since we've seen a really big, bad new variant. And so if you are up to date, you've had that protection against Omicron. If you're not up to date, please do come up to date, really. But I am not anticipating at this point there will be another vaccine, another booster that is recommended probably until next fall. And I think that's good. It'll be something, we'll probably be doing this ahead of winter surges. We're going to increasingly, I think, be thinking about COVID like we do other respiratory viruses. So I hope that helps you understand that. So if you're up to date with the bivalent shot, there isn't anything next right now. We'll be monitoring. I would expect that next fall there will probably be another updated vaccine that has been made to match whatever is circulating at that point from COVID. And we will certainly let you know if there's anything in the meantime. So don't get worried that you're not protected. If you're 4 months out, that means you did a good job of getting vaccinated early. You are in a good place. Everything we are still seeing is Omicron. And yes, the vaccines continue to show, a good level of protection, especially against severe outcomes. If you're up to date with the vaccine. Okay, let's take another one for you,
sure.
and then we'll get some more COVID ones. So, a number of interesting questions here.
Great.
Let's take Juan Rangel on Facebook says, is the treatment not trauma model and the care team the same thing?
That's a good question. So, the treatment not trauma model has really kind of focused on two things, as I understand it, which is one, been reopening closed mental health clinics that the city used to operate that were closed by Mayor Emanuel over a decade ago, and then having 911 mental health teams operate out of those closed clinics. So the similarity between what we're doing in care and what that calls for is having mental health professionals respond to 911 calls, right? And we completely agree with that, and we're already doing that. The difference is we've really focused on funding mental health clinics all around the city of Chicago that the county, state, and federal government regulate and operate as well, not just focusing on the 5 clinics that the city operates. And the reason for that is in a city of 3 million, almost 3 million people, you have to get way more clinics than the city is ever going to directly operate in order to get into every community.
Right, I hear people talking about, I want to have 6 clinics, 12 clinics, 20 clinics.
Yeah, I mean, in 2.7
we have
million,
like 200
we have
clinics.
like 200 clinics, right. A lot of people don't realize that. And so if you
200 clinics that are safety net. And that's the part we've worked to build and stitch together.
So if you go to mentalhealth.chicago.gov and you click on our resource finder, it's on the upper left-hand corner of the website, just type in your zip code or the neighborhood that you live in, and you'll see all the clinics around you that are regulated and funded by the government, either the city, county, state, or federal government. They're no barrier mental health clinics. So one, that's the biggest difference, but we totally agree with the folks that advocate for treatment, not trauma, that we really need to take a health-forward approach that's led by mental health professionals, by paramedics, by peer recovery specialists who answer 911 calls when they have those health and social components to them.
All right, good. So I see there's a lot of back and forth happening on the mayor's page, particularly around vaccines. People saying the booster will kill you, only natural immunity, unhappy with me. I'm not going to take these one by one. I've done a lot of this in the past. The data that I show you is City of Chicago data. It is not lies. It is not made up. It is reported by law. Every single time anybody with COVID-19 is admitted to the hospital, anytime there is a positive COVID test in a laboratory, it is reported by law to the health department. That is the data that we share out. It does not include home tests. It does not include rumors. It does not include things that we might hear. I believe very strongly in making sure that the data that we share is as transparent as possible. That's why we continue to add to it. And we can debate what we should do about a health situation. I really don't tolerate debating what the data itself is. So I encourage you, go, we've got it all available. You can download it, you can look at it yourself. But this is how COVID is showing up right now in the city of Chicago. We report every single thing that comes in. And that's, I think, what I'll say sort of on that. In terms of questions, so we've got a number, I'm going to take one more COVID and then we'll come to you.
Yep.
There's a number of good questions, sort of a little bit more about kind of the dashboard and some data. So Patty Graff on Facebook is asking, what specific vaccinated groups are being hospitalized and dying? Elderly is a broad spectrum. Kelly Friel from Facebook is saying, why are there so many young people that are dying? Riley Scully from Facebook is saying, how many cases and deaths occurred in someone who was vaccinated? Were they counted as unvaccinated? And someone, I know that the city is at low. It seems like people in my neighborhood are sick right now. Can I track that specifically? So I'm going to I don't usually do this, but I'm going to turn back to the dashboard a second and show you how you can actually look some of these up yourself, so that just to remind you kind of what that's available. So can you guys pull the dashboard back up for me, please? So first of all, this question of who is dying from COVID these days. I just want to remind you that if you click right here on cases, if you, let's say, you can move this date range and say, let's look, in the last, 2 months or so. So let's say November 25th to January 25th. If I move this up here and I say cumulative totals, this will actually show me in the last 2 months, 82 Chicagoans have died from COVID. 2,323 Chicagoans have been hospitalized, and almost 30,000 people have been diagnosed in the lab. You can see here's what the case rate looks like overall. Here's what the hospitalizations have looked like. Here's what the deaths have looked like. But you can also go into more detail. So if we go age here, so again, this is just the last 2 months. Who has died from COVID in the last 2 months in Chicago? 52 of those 82 deaths are people over the age of 80. So the reason that I was really highlighting that I'm worried that only 36% of Chicagoans over the age of 80 have had that Omicron vaccine is because that is who is dying from COVID the most. Next are people in their 70s, 17 of the 82 deaths, right, in the last 2 months. You can see there have been 6 Chicagoans in their 60s, 4 in their 50s, and 3 in their 30s in the last 2 months who have died from COVID-19 with that final finding on the death certificate, okay? And again, this is about sort of having official data reporting. And so if you want to, if you want to look by gender, if you want to look by race, ethnicity, you've got maps over here on the right. What is, feel free to explore any of that. For deaths, for hospitalizations, we continue to see in purple here, Black Chicagoans disproportionately being hospitalized with COVID. That is largely related to still somewhat lower vaccination rates, especially in Black Chicagoans. But a lot of older white Chicagoans as well being hospitalized and especially dying. So you can explore that there, those of you who want to understand what's happening right now. If you want to know in your neighborhood, we continue to update this every week, our cases by zip code. If I say, this is sort of the time overall, but if I go to weekly here, this defaults to, a week ago. Here is where we are seeing deaths, most recently in Chicago from COVID. Here is where we are seeing cases, in this most recent week and counts. What does that look like? If you want to see what the percent positivity looks like, all of this is still being updated on a weekly basis. If you want to see what testing, and again, this is lab-based testing, you'll see a lot on the Southwest side. We know that especially people who may not be insured, may not be documented, may be more likely to be going to federally qualified health centers or the other supports the city has stood up. You see, it's not just about where is COVID, it's understanding the social things that lay underneath this. But please, any of these kinds of questions, all of this is still available and updated every single week, and you can always explore that. And to the question around sort of what's happening with vaccine effectiveness, so if you come down here and click on vaccine effectiveness, we also update this every single week. So this is where, to the question of are these people who were just vaccinated, et cetera, we do a match every single time somebody is diagnosed with COVID, hospitalized with COVID, or dies from COVID. We do a match against the state vaccine registry to say, do we have a record of this person being vaccinated or not? Are they boosted? Are they fully, that is where that data is coming from. Every single week we're updating it. So for deaths in particular, since Omicron became dominant, unvaccinated people who at the population level we do not have a record of vaccine for, are about 2.5 times more likely to die from COVID compared to people who are fully vaccinated. And then people who are unvaccinated, are about 5.3 times more likely to die than people who have been boosted and are kind of up to date with vaccine. And this will show you sort of the exact numbers. You can download this. You can look at this by age group if you want to. You can look at hospitalizations. It's all in here, and I encourage you to explore where you have more questions. So thanks for indulging me on pulling that back up, but I like to show people how to answer their own questions where they have them. Okay, Matt, let's do a few more for you.
Okay.
Number of questions here.
Great.
Barbara Stephen on Facebook is asking, for Hotel 166, now post-COVID, et cetera, what happens to the people once they are stabilized? What resources can be provided for them? And then there's also a question, why don't you just start with that one?
Yeah, so that's a great question. So the goal when somebody has achieved stabilization, you can stay in this housing, as we're imagining it, up to 6 months. And then it's linking into a permanent supportive option for that person. And that could be the person getting linked into a permanent supportive apartment. It could be a communal living environment that they want to live in. In some cases, folks have lost relationships with family because of some of the consequences of their untreated mental illness or addiction, and so want to go live with family members. One thing we learned from Hotel 166 is sometimes folks had very significant health issues, unfortunately, that were terminal, that had been undiagnosed, or that were going to continue to get worse, like dementia, like advanced cancer. And so you might be linking somebody into a nursing facility, a specialized mental health rehabilitation unit. But no one is being pushed out without a plan. Right. That defeats the whole purpose of the model. Is you want to get to know each person really, really well, so that you understand with them, with their guidance, what's the best next step for this person. Because with this population, what ends up happening, they get a lot of health care in the emergency system, in emergency departments, and people don't get to know them. So people often don't figure out what are the deepest underlying issues here that we need to work on, because they're being seen at this emergency department for 10 hours and this emergency department for 4 hours. And so you really want to make sure you stick the permanent housing. Otherwise, you've just kind of undermined the whole thing that you're driving towards.
Yeah, and I think one thing that makes this a little different than, we so appreciate our colleagues at the Department of Family and Support Services who are working to, expand and make available that sort of emergency shelter capability. We really appreciate our colleagues at the Department of Housing that are continuing to work to build, more affordable housing, and what does it look like to have that supportive housing. This piece is really health focused, stabilizing health. I want to kind of emphasize that. And people, the way we're imagining this, kind of like we did for Hotel 166, is that somebody might stay for 6 months in this kind of hotel setting.
Right.
While we really, you have the chance to adjust people's medications. It's not being in a hospital. It's not being fully, you're not so sick that you need to be hospitalized to get stabilized. But especially for mental health and substance use issues, often you need to really, you might try a medication and monitor people for a week or two, and how are they doing? And there's just it's a need, and it's not being met otherwise. And so this is a very unusual thing for us to be doing, but nobody else is doing it. And I feel strongly that where the city needs to step in are in spaces that we see a lot of unmet need, but nobody else is stepping in. And I think, frankly, a lot of the conversation has been around sort of what's happening with outpatient clinics. That's an important conversation, and we can talk a little more about that. We, of course, want to make sure people can get outpatient care. But my biggest concern in this city are people who are not really stable enough to make and keep a 10 a.m. appointment on a Tuesday with an outpatient provider. That's right. It's the people who are constantly sort of, maybe they're not stably housed, they're off their medications. We really need to bring services out of clinics to them, whether that's through the 911 system, whether that's through care-based teams. We're also, since COVID, we didn't talk about this, but folks may not know, we are finally funding, because we got resources with COVID, we're funding behavioral health care, mental health care, substance use care, primary health care in the shelters, right? You didn't used to be able to get that sort of at the shelters. And so we're really trying to, where you can kind of inject health and think about those health outcomes. Yes, housing first, we want to get folks housed, but for many people, you've got to get the health stabilized to even be
and that's why if you go back to 2019, the city was serving about 3,500 people a year for mental health services. Just, I want you all to know, this past year, we served over 60,000 people for mental health services. Well, how did we do that?
3,600
to
60,000.
What is that? A 15
with City of Chicago dollars.
15-fold increase or something. And the reason we did that is because we are integrating mental health services in all of these different settings. Exactly what you just said. So all the shelters. We're now starting to put mental health in libraries, right? We're putting them in schools. We're putting them in clinics where people get their primary care. So, you go to see your doctor for your blood pressure, but you're also depressed, right? And then you, of course, still have mental health clinics, but you also have teams. We've got to diversify the way we think about this. We're too wedded to this very old school, outdated model that mental health services means you go to a clinic in person, you have an hour-long appointment. That's not what it looks like anymore. It could look like that. It looks like teams. It looks like mental health services in all these different other places we just mentioned. It means telehealth, so maybe you're not in person. It means coaching, so maybe it's brief sessions where you're talking to a mental health professional while you're in the midst of a crisis. That actually, crisis is an opportunity. We learn a lot about ourselves and other people in those moments, and it's actually not waiting for your next appointment. It's calling your therapist right then. I tell my patients, call me when you're in crisis, because we want to figure out the opportunity there. So I think we're really moving in a promising direction.
Yeah, and it's both, right? It's making sure there are clinical services available to you no matter who you are, no matter what your income status, but also where are the gaps? I'm going to stick on this because there are a lot of good questions, and you're here visiting. Eric Martin from Facebook says, so actually I'm going to give you two together.
Great.
Eric Martin on Facebook says, so if we're not going to reopen those mental health clinics, how are you making sure to reach Chicagoans in need of mental health services?
Great question.
Hold on. I'm going to give you a second one kind of at the same time. Liz from Twitter says, what's a number you could call to get the mentally ill homeless out of the baggage claim area in O'Hare and get them help? So
okay, so let me say, so thank you, Eric, for your first question. So I mentioned if you go to mentalhealth.chicago.gov, you'll see all the clinics around the city of Chicago that we fund. We fund all of those clinics, and they are either operated by the city, the county, the state, or the federal government. There's hundreds of them. And we are getting to a point where we literally are funding a clinic in every single community area in the city, and in many cases, in the historically disinvested communities, multiple clinics in each community area.
We're not funding the whole clinic, just to be clear.
No.
We might be paying to put a child psychiatrist into a pediatric office. We might be paying to put a licensed clinical social worker into a hospital setting or a food pantry setting. So they're not, right? It's about stitching together the resources that exist and then pulling a sort of a safety net system together where we just haven't had one.
The other thing is we've really expanded our city mental health staff. So when I started with the city, which was in the summer of 2019, hard to believe it was almost 4 years ago, we had 50 mental health staff that were at the health department. When you look at our budgets now, Dr. Arwady, and I appreciate the mayor, you, city council members who've been really passionate about this, we now have 100 staff. The difference, Eric, is that not all of those staff are working in a clinic. So I'm hiring mental health staff that answer 911 calls. I'm hiring mental health staff that are going to go into a library and start an extension clinic in that library in your community. So some people don't want to go to a mental health clinic. They want to go to their library where they can get their mental health services, right? So the city's role is to look at all of those clinics around the city and say, where are the gaps? And we're going to hire clinicians to fill those gaps. And that's what we're doing right now. And I will continue to do it because there's more work to be done. The second question, can you remind me?
Yes, Liz is wondering sort of this, what's a number you can call? She's wondering about seeing people who are mentally ill. She's specifically saying the baggage claim at O'Hare, but similar conversations.
So multiple things. So one, we're working on establishing a mental health presence, a CDPH mental health presence at O'Hare. We also have a number of nonprofit organizations that work at O'Hare to address the specific issue that you're referencing, Liz. But as for numbers, if you see somebody who's experiencing a mental health crisis, you can call 988 or you can call 911.
What's 988?
And I'll explain what 988 is. It's a national 3-digit mental health crisis line that was established by the federal government. It launched last July. It's statewide, it's nationwide. Anybody can call it, it's free, and you get connected to a mental health counselor. It's a great option for folks who might have a mental health issue that can be resolved over the phone. The other option is if somebody is in an emergency and they need a service in 10 minutes, 15 minutes, that's when you call 911. And that's why we have these mental health teams. The last thing I would mention is we just launched a 211 this past Friday. 211 is now a citywide line that anyone can call that gets people connected to human and social services, including mental health services. So let's say, to give an example, I have a child who is experiencing extreme anxiety that is impacting them in school and I don't know what to do. You can call 211 and say, I live in South Chicago and I'm looking for a pediatric mental health provider that can help our family, and they'll help you get that number. You can also go to mentalhealth.chicago.gov, type in your neighborhood, type in your zip code. You'll see all the clinics that we fund in your neighborhood and you can call those.
Yeah, and I would just maybe add, thank you for that.
Sure.
I would add, Liz, I think your question here is sort of as opposed to, I know this person and I'm worried about their mental health. It's like I'm seeing someone who kind of may need help. And I've been very pleased to see a lot of our, again, partners across the city make additional investments in this space. Just as of January 1st, I know there's been some new contracts and resources to the tune of, I think, about $1 million to specifically focus on people who are at O'Hare or around O'Hare or kind of, in transit there. I take the L every day. I also see the people who are using the transit system, who are not choosing to go into shelter, who have a lot of needs. The health department and the Department of Family and Support Services are also funding and supporting additional work to do outreach kind of in some of these higher need public settings. And so those are new. And again, this is not all the health department. We kind of take this health first approach, but there's a lot working on this.
But the example of here is a good one because
Yeah.
that's not something that's going to be solved by a clinic.
Right.
It's going to be solved by having mental health teams that go out into those terminals, that
That's right.
engage people on the trains. And usually what we need to do in those situations, people that sleep outside, so under bridges, in encampments, in parks, on the trains, in airport terminals, as a general rule, need housing plus significant healthcare services. And we know that from the research. People don't tend to sleep outside because they lost their job, because there's disagreements in the home. People tend to end up outside because they have significant health issues, unmet behavioral health issues, and usually sleeping in a shelter where it's loud, where there are lots of rules, it's typically exacerbating of people's symptoms. And so that's why some of the strategies we've talked about, buying the hotel, team-based care, housing plus services, that's the future of addressing that challenge.
Yeah, and I'm going to be really honest. We do not have all the answers around this. We continue to have resource needs, but behind the scenes, while out front, you've seen me talking a whole lot about COVID. I think behind the scenes, really, the work that I've been able to do with Matt and his entire team that has doubled during COVID, that is really thinking about this. Our goal is to change the conversation, not because we care about the conversation, but because we care deeply about making sure that no matter who you are in the city of Chicago, when you have unmet health needs, we can be there, sort of
That's
as
right.
that safety net to the safety net. And I think the clinics are an important piece of this. We've also, we didn't talk about this, but we've added pediatric clinicians to our own CDPH clinics. We didn't used to take care of any kids. We've added evening hours. We've done this expansion work. It's not sort of one or the other.
No, not at all.
It's about continuing to grow. And we saw how much was the budget increase? 7 times, I think.
Yeah, when I started in 2019, we had a $12 million budget. When you look at all the increases we got in the city's corporate general operating account, in some of our other grant accounts, and then with COVID dollars, we have an $89 million budget this year. So that's a more than 7-fold increase. And I think we're seeing people tell their mental health stories. A lot. I've really appreciated elected officials who've talked about, their family members or their own personal struggles with mental health. I lost my uncle to suicide about 5 years ago, with whom I was very close. And I think about where were the system misses for him? Like, he was never going to go to a mental health clinic.
Yeah.
It would have been his primary care doctor, right?
Yeah.
So we all have those stories, and I think, telling your stories on social media, engaging your neighbors. Sometimes people are hurting too much to ask for help, so we have to start the conversation. It's saying to your friend, I've noticed it seems like there might be something that you're struggling with that's causing hurt in your life. I've noticed you don't seem yourself. Is there anything I can do to help? Would you feel comfortable talking about it? Sometimes we place the assumption that the other person's going to ask us for what they need, and sometimes they do, but oftentimes they don't. So that's an encouragement to you.
All right, thanks. We are just about at time. I know that we didn't get, I wanted to sort of get through some more of these mental health focused questions while you were here. I see those of you, I see DS Shin on Facebook, I see Alexandria Deanne on Facebook, both commenting on the fact that a lot of people are watching The Last of Us and they're wondering about the scientific possibility of a
I just
fungus
watched that last
pandemic and risk for fungal infections. Is there a concern about valley fever? Could it come here?
Yeah.
I'm going to take that on next week. I do not have a high concern for a major fungal pandemic. I actually have worked, believe it or not, on fungus outbreaks. I did a histoplasmosis major outbreak in Illinois. We'll talk a little bit about fungus, but there are a lot of things that are heightened for TV in The Last of Us. I don't think anybody is going to ever underestimate sort of how disruptive a pandemic can be. But that's sort of an interesting topic. So we'll take that on next week if you tune back in a little more detail. And I do see those of you, I appreciate the comments. of folks saying, Shannon Bruckner, I see you. Live streams are very informative. Brooke Eagles noting there were a lot of people wearing masks downtown yesterday. It's very impressive. I think when it's cold also, it encourages folks to, kind of double up and put that on. So if we did not get your COVID question today, we will be back next Tuesday, February 7th. Just as a note, if you are watching on the mayor's page specifically and want to tune in, follow Chai Public Health, okay? Chai Public Health on Twitter, Chai Public Health on Facebook. Sometimes we're on the mayor's stream, sometimes we're not. It depends a little bit what else is happening in the city. But follow us at Chai Public Health if you want to continue to be part of these conversations. I want to thank you for really the thoughtful questions.
Yeah, great questions.
We don't have all the answers, okay, around mental health. And your questions, just like they do for COVID, they help us kind of sharpen where do we need to go? Where are the gaps? What are those answers around in this situation? What number I call? How do I get connected? We are still doing a whole lot of work on this. There's a lot to do still, but I learn a lot when I talk with people like Matt Richards, our Deputy Commissioner for Behavioral Health, and to people all over this city working to really solve this problem. So thank you again for being on, and indirectly to the team. We will be back next Tuesday. Regular time, 11 a.m. Follow Chai Public Health to stream along with us there. Thanks. Have a really good week. Yay, we're at a low COVID level. We're not done, but it means we can devote additional conversations to these kinds of topics. Thanks again. Bye-bye.